Hello everyone, welcome to Navi podcast. I'm Dr. Suman. Did my MCH plastic surgery from Safdarjung Hospital in 2017, and at present I'm working as a consultant in burns and plastic surgery as an associate professor at RML Hospital, Delhi. Today, it's a great honor to invite Dr. Pramod Kumar sir to this podcast. He was a former consultant plastic surgeon at Ministry of Health, Zaza in Saudi Arabia, and he also was a former professor and head department of burns and plastic surgery, Kasturba Medical College, Manipal University, Karnataka. He has more than 160 national and international publications. He was the past president and founder of Society of Wound Care and Health and active member of various national associations. He has authored 2 books and contributed several chapters in books. He served as editor of IJPS and Journal of Society of Wound Care and Research, and he was a reviewer of several index international journals such as PRS Global Open, Burns, and IJPS. He has a special interest in humanitarian ground and volunteered as a cleft surgeon and plastic surgeon for Rota Plast International Organization. And I welcome you, sir, to this podcast.
Thank you for having me. I'm honored to be here, and I'm looking forward to discuss this topic, which is incredibly important and often misunderstood. Burn fluid, I can very safely say, burn fluid resuscitation is a double-edged weapon, and I appreciate you dedicating this platform to a subject that affects so many burn patients' lives. I think we will start your presentation. Please start with it.
Okay, thank you, sir. Today, our topic of presentation is an article on renal function after severe burn trauma and effects of reducing resuscitation, fluid volume, and changing fluid tonicity. It was published in the Burns Journal in 2025. It was done in Netherlands by Rolf K. Gegengak. Coming to the introduction, severe burn trauma is a major physiological stressor that significantly impairs renal function. The incidence of acute kidney injury is around 38% of severe burn cases, and acute kidney injury is independently associated with increased mortality and morbidity. Pathophysiology is a complex two-phase assault comprising of acute renal failure occurring within 3 days and late renal failure after 3 days post-burn. The causes of acute renal failure occurring within 3 days of burns include systemic inflammatory response, cardiac dysfunction, hypovolemia, and hypervolemia. And the causes of late renal failure include sepsis and septic shock, multi-organ failure, or complications of fluid resuscitation and nephrotoxic medications. And because of over-resuscitation, it can lead to severe edema, pulmonary complications, acute compartment syndrome, intra-abdominal pressure, and multi-organ failure, and increased mortality. So the main question is how much fluid is just right. So widely used fixed rate formulas like the Parkland formula can lead to fluid creep and over-resuscitation. So optimizing fluid resuscitation volume can be beneficial. The goal is to maintain organ perfusion, maintain renal and organ function. So optimizing fluid resuscitation volume is a goal-directed therapy. Start with a calculated rate, then titrate based on urine output. This individual approach aims to minimize the risk of over-resuscitation. Fluid volume reduction using hypertonic saline. There is a growing evidence linking hypertonic solution to acute kidney injury and increased mortality. So there are ongoing debates like what is the role of albumin? It may reduce total fluid volume, but timing and indication lack consensus. And the role of fresh frozen plasma, it is said that it may reduce endothelial leakage, but evidence is still emerging. And in 2018, the Dutch Society has revised the guidelines from old protocol that is 4 ml per kg per TBS of hypertonic saline containing sodium of 222 milliequivalents per liter to a revised protocol that is 3 ml per kg TBS of isotonic saline, mainly ringer lactate. So, sir, here my question is, we have different formulas. So, which formula we should follow, sir, and especially now setup?
Yeah, there are various formulas, both crystalloid, colloid, and also hypertonic saline formula. Hypertonic saline formula nowadays is not recommended. Maybe we'll that later. The colloid and crystalloid formula are commonly used. I feel it is important to understand the finer point for starting this. We usually use the crystalloid formula as a backbone of fluid transfusion. And the daily requirement of every person is same. So that is to be given to each and every person. Over that, top that we will have to give some extra fluid, which will be equal to burn loss.
Okay, sir.
So we use modified Brooks formula, crystalloid only formula
Okay,
as
sir.
an initial guide. And this is 2 ml per kg per person body weight, and same divided into two parts, 8 hours and 16 hours,
Okay,
plus
sir.
daily requirement. And day two, we use 1 ml per kg per person plus daily requirement. We give bolus 500 ml crystalloid within 30 minutes if required. There
Okay,
is growing evidence that this bolus is not beneficial for the children, and sometimes it is harmful. There is a study called FIST trial.
okay, sir.
To expand the plasma volume to reduce the fluid load, we are using colloids, albumin within after 24 hours if required, individualized, not in all cases. There is need to develop an optimized resuscitation formula or protocol, and in which the normalization and capillary pore should be the end goal, which is not now. And whatever present goals are there for endpoint, therapeutic endpoint, these are basically supportive, and this should be made supportive. So I am for changing the resuscitation goals. And whatever you do, since your backbone is crystalloid, you will develop some fluid creep. And to reduce this fluid creep, we will have to use RRT and diuretics.
Okay, sir.
I think this makes the subject clear. If you have any other question, you can.
Sir, how do you manage in cases of late presentation, sir?
Okay, the late presentations, there is no proper guideline available, and this is very confusing.
Okay, sir.
While managing the late cases, we will have to take different situations when we get the patients. I'll broadly take important situation which we get usually. First situation is it comes late but within 8 hours. In
Okay,
those
sir.
cases, 8 hours fluid will be transfused in the remaining hours. But sometimes it is 2 hours and the fluid rate becomes very high. Then we limit the fluid rate to 1000 ml per hour. We
Okay,
continue 1000 ml per hour. We encroach in the 16 hours duration. And once it is finished, we start the next 16-hour fluid and finish it within remaining of the 16 hours. I
okay.
think it is clear.
Yes, sir. Yes, sir.
And uh, uh, if there is problem, bolus and all those things, fine adjustment is done.
Okay, sir.
Burn situation maybe, but if the patient comes after 8 hours, then it is real problem. That time we will have to see the vitals of the patients, and accordingly we will start the IV fluid. We give fast fluid to reach the some near the end point, end therapeutic goal, and you can say the urine output, initially BP and MAP. MAP usually in resuscitation period, initial resuscitation period, we take is above 60 millimeter of mercury.
Okay,
And urine output, once it's available, 0.5 to 1 ml per kg per hour.
okay, sir.
And then we keep on going fine tuning as usual, depending on. Then third situation is patient is in sepsis. It is coming late and some early sepsis can occur, and target endpoint here will change. And there's certain additional things we'll have to use because there will be tissue hypoxia also. So in these cases, sepsis cases, our MAP increases to 16 above 65 millimeter mercury. Sometimes in ICU we use CVP also. The people are against many people, many places, but now with good antibiotics we are using 8 to 10 millimeter mercury. And then in these cases, patient, since it is in sepsis, there is chances of tissue hypoxia. To measure that, we do venous oxygen saturation, and which should be above 70%. And lactate we also measure and maintain a target point. So we'll discuss maybe in the due course of time. If the patient is hypovolemic shock, the resuscitation fluid may increase up to 30% if we're using crystalloid. And we do that, and we avoid, at this stage, we avoid any albumin or chloride. Then the next situation, as we discussed earlier in the earlier slides, the raised intra-abdominal pressure above 30 millimeter of mercury and crystalloid fluid can lead to perirenal edema, interstitial edema, and compression, leading to reduced supply to the kidney, and the AKI can develop. In this situation, if a scar is there, we do H-shaped scarotomy, as we all know, and give diuretics, and this improves the AKI. Failure, and yeah, in these cases, in abdominal compartment syndrome is there, we do ABG and chest because of the diaphragm problem of the pushing of the diaphragm upwards.
Yes, sir.
Failure to respond to at this stage due to standard protocol could be because of carbon monoxide, could be because of cardiac causes, could be because of organ failure.
Okay,
In these cases, we will have to first measure the CVP, maintain the level, and then achieve the normal level, and then correct the albumin level. Noradrenaline is given after that. We should not give adrenaline in hypovolemia, because we might have seen that gangrene of both hand and both legs.
Yes, sir.
It is because of adrenaline if we start in hypovolemia. If irreversible shock appears, better to go for comfort care. That's all. You want anything else? You can
Yes,
ask.
sir. Yes, sir. I think you have answered the third question also, sir, in this. Thank you so much, sir. We'll proceed to the next slide.
Okay.
Coming to the objectives, the study aimed to analyze the revised Dutch Society guidelines and its effects on the change protocol and renal function, and compared the outcome of new resuscitation strategy with existing literature. Coming to the methods, it included all consecutive adult burn patients admitted in ICU who were resuscitated within 2 years before the protocol change and after 2.5 years of protocol change. The study design is a retrospective study, a single center study comprising of 108 patients. 52 were in 4 ml group and 56 were in 3 ml group. Inclusion criteria include all burn patients, adult patients of at least 15% of TBSA is involved, and exclusion criteria involved all patients who denied the treatment and having severe comorbidities. Coming to the resuscitation protocol, before the Dutch guidelines, that is mid 2018, Parkland formula was used, comprising of 4 ml per kg TBSA with a hypotonic saline for the 2.5 years, and after following the protocol change, 3 ml per kg TBSA of isotonic saline was used for 2.5 years. So it is a total of 5-year study. All electric burns over 5 years are resuscitated with 4 ml per kg TBSA using ringer lactate, and all received 20% albumin at a fixed rate of 1 ml per kg per hour starting 12 hours post-burn trauma. And the rate was adjusted hourly based on the urine output, targeting at least more than 0.5 ml per kg per hour urine output. So this is the overview of resuscitation protocol. Here, one axis you can see the infusion rate, and on the other axis you see the time interval. So the urine output is the main target, and the infusion rate is titrated according to the urine output. And if there is persistent oliguria, then as sir said, they have monitored all the other central venous pressure, focused ultrasound and other things. And in case there is fluid, if the patient is not responding to the fluid, then there can be reduced cardiac function. And at the end, they have advised inotropic support and vasopressor support with the help of physician. Coming to the outcomes, primary outcome was measured by glomerular filtration rate, creatinine levels, and urine output during the first 7 days. And the secondary outcome in terms of mortality, length of ICU stay, length of hospital stay, and the duration of mechanical ventilation. AK is classified according to the kidney disease improving global outcomes, which categorize into stages based on changes in creatinine and urine output. So, sir, Sir, I think you have answered this question. I just want to ask again, how do you titrate the fluid after initial management? Do you use any extra parameters for titrating the fluid other than the urine output?
Okay. So fluid resuscitation is a double-edged weapon that we all know. The goal is simple and very clear. it is done to maintain perfusion and organ function without tipping into the overload. Okay, so start with the standard protocol, and from there adjustment is made hourly depending upon the therapeutic goal. So we have just discussed the therapeutic goal. Same therapeutic goal is there. First of all, we will have to maintain the urine output from at least 0.5 ml per kg per hour. If the output is too low, we fine tune the infusion rate. Typically, in 50 to 100 ml per hour steps. What I mean to say is, if you are giving 200 ml and urine output is low, you increase to 250 ml.
Okay,
or reduce to 50 ml. 50 to 100 ml steps we do. And electric burn can produce myoglobinuria, and target is high and adjusted accordingly. We, as an example, we give diuretics and alkalinization.
Okay, sir.
Urine output is not only the whole story. We will have to track arterial blood pressure, MAP, lactate, acid-base balance, and central venous pressure. I told you, and SpO2. That is venous oxygenation.
Yes, sir.
The advanced tools are pico monitoring for cardiac function and blood flow, and stroke volume optimization is done, because these things are done by cardiologists, so they will be better to tell you more about this.
Yes.
I believe that serial AG albumin globulin ratio should be monitored definitely, because it may help to calibrate the capillary pore, and the best time to administer albumin when capillary pore is returning towards normal, so that the leak of albumin out of the capillary will be less.
Okay.
The thing you want to know, I'll tell you.
Okay. Sir, you have mentioned use of diuretics. When is usually advisable, sir? Because some people give in the early period. Is it advisable to use diuretics to maintain the urine output, sir, in the initial 24 hours?
There is a lot of controversy, and I always keep having discussion with the ICU people.
Okay, sir.
See, what happens if the fluid creep is more, and you are seeing a lot of edema, abdominal compartment like things in early stage, better to use diuretic rather than going to RRT. If kidney function is normal, still kidney is there. There is I always tell that people don't agree or may not agree. When there is a dialysis unit functioning in your body, there is no need of RRT and things like that.
Okay, sir.
And I told you that this, because of the fluid creep, there is compression on the perirenal area and reduced vascularity of the kidney. That may lead to reduced urine output. If you give adequate diuretic at this stage, maybe it will return to, and I have seen returning many. I have shown people the urine output is reduced. They say go for RRT. I have given Lasix and it improves. Okay. And no RRT is needed. So these things has to be done, but it is my experience. Whether people agree or not, that is. But definitely, if fluid creep is there, you can try insulin. Diuretics.
Yes. Yes, sir. The point is, I think under monitored conditions, we can still give diuretics in our patients.
Yeah, definitely, we can give. And for electric burn or not, for myoglobinuria, hemoglobinuria, you will have to give.
Yes,
and
sir.
You will have to alkalize. Since the very beginning, you will have to give to flush the kidney.
Yes, sir. Okay, sir. Thank you, sir. Coming to the statistical analysis, the software used is RStudio version 2022, and the statistical analysis were the student t-test, odds ratio, and analysis of variance. Coming to the results, this is the basic patient characteristics chart. You can see the mean age is around 45 years in both the groups, and there is only one electric burn in 4 ml group, and the median TBSA is around 22%. And coming to the comorbidities, renal pre-existing renal failure is present in 4 patients in both the groups, So more or less the baseline characteristics are matching in both the groups. Coming to the fluid balance, if you see the fluid balance at the time of 24 hours, the infusion rate in 3 ml group is around 3.3 ml per plus or minus 1.7 ml per kg per TBSA. And in case of 4 ml per kg, that is 4.6 plus or minus 1.8 ml per kg TBSA. And coming to the urine output, it is more or less the same at around 8, 12, 24, and up to 72 hours. The urine output is maintained in both the groups and it is matching. Coming to the net fluid balance, that is the total fluid administered by the urine output, it is slightly more in case of 4 ml per kg TBSA. And coming to the urine output during the first 3 days, there is no statistical significance between the two groups. And similar with the creatinine concentration during the 7-day course, there is no statistical significance. Similarly, GFR rate is also during the 7-day course, there is no statistical difference between two groups. The volume of resuscitation was higher in less than 20% and 20 to 90% groups compared to greater than 20% TBSA group, and the p-value is significant in this. Coming to the mortality and hospital stay, the mortality is more or less the same. The main one important thing is the length of hospital stay, which is showing significant difference. It is more in case of 4 ml per kg TBSA compared with the 3 ml group. And the acute kidney injury is more or less the same with both the groups. And there is no significant difference between the incidence of acute kidney injury at the time of admission and the requirement of renal replacement therapy. And the mechanical ventilation also, there is no significant difference and the p-value is not showing any significance. Coming to the acid-base status, when compared to the hypertonic saline, the 3 ml group has slightly lower pH, lower sodium levels, higher albumin, lower bicarbonate levels, and there is no significant difference in chloride and lactate levels. Sir, one more question is, if the patient presented with comorbidities like renal failure, heart disease, diabetes, how different is the fluid management from the normal individual, and how to manage and adjust the titration in these patients?
Okay. In pre-existing comorbidities, we should remember, we must freely communicate and to the various specialties. What I mean to say is multidisciplinary care is advised. In general, the genes of comorbidity, the ultimate aim is same: maintain perfusion, preserve organ function, and avoid fluid overload. The various comorbidities which we see is the renal failure, where the kidney cannot handle extra fluid. In these situations, we will have to match the urine output with the infusion given. What I mean to say is urine output plus insensible losses. And if there is, and we will watch for electrolyte imbalance. If there is a fluid creep and electrolyte imbalance is there, or some other indications of RRT, we must go for RRT. And diuretics may help in some cases when the kidney function is normal. In heart disease also, restrictive fluid protocol should be used because this can lead to pulmonary edema, cardiac failure, and pulmonary. Advanced monitoring should be, the cardiac monitoring should be done in these cases. Diuretics, inotropes, vasopressors should be used to maintain the BP. In chronic obstructive disease, and a restrictive approach here also, and monitoring of the oxygen and blood gases will help. In diabetes and all conditions, glucose and potassium can go intracellular. So this is to be monitored carefully, blood glucose level. And insulin should be given to stabilize the metabolism. That will help to reduce the morbidity and mortality in these cases. In hypertension event, aggressive fluid management worsens the organ damage. Careful blood pressure monitoring, keeping under control, renal monitoring is very important. And you can say in hypertension cases, there might be pre-existing kidney cardiac disease, cardiac dysfunction, which we'll have to diagnose and sometimes vasopressors are needed to maintain the vitals without overloading. And this all major comorbidity. Any other thing if you want? You can.
Okay, sir. Thank you, sir. We'll go to the next slide, sir. Coming to this discussion part, the first thing is isotonic versus hypertonic fluid resuscitation. There is no significant difference in renal function as assessed by the glomerular filtration rate, plasma creatinine concentration, urine output, and the incidence of acute kidney injury between the two groups. The study indicates that reducing the initial resuscitation volume and changing from hypertonic to isotonic saline solution did not adversely affect renal function. These findings are similar to other studies like Pizzo et al. And meta-analysis by Folkestad. Manson et al. Found a higher probability of developing acute kidney injury resuscitated with fluid less than 4 ml per kg TBSA. The factors associated with high risk of acute kidney injury, including larger burn size, elevated SOFA and Apache score, and higher incidence of mechanical ventilation. These findings are relatively low in the study compared to others, potentially explain the lower acute kidney injury incidence. The change in tonicity could introduce mixed effects on the patients being resuscitated, including an increase in fluid creep, increased risk of hypernatremia associated acute kidney injury, natriuresis due to higher sodium excretion, leading to potential resuscitation and influence on patient acid-base status. The results of study might suggest a minimal effect of the change in tonicity, as the data show a decrease in fluid creep with similar urine output and rates of acute kidney injury and renal replacement therapy in both the groups. Sir, again coming to the basics, sir, which fluid to be given, sir? Whether it is a hypertonic and isotonic and or hypotonic, and why, sir?
Hypotonic solution is out of question because hypotonic fluid will enter into the cells and cell will swell and there will be it will burst and there will be a lot of problems and it's not recommended and it cannot be used.
Okay, sir.
But hypertonic saline was earlier used, but since long back, maybe 4 or 5 decades, people are against this hypertonic saline, and nowadays it's not being used. So hypertonic saline can produce hypernatremia, various kind of electrolyte disturbances, kidney damage, and so many things it can produce. So the hypertonic solution also nowadays, almost all guidelines, they do not recommend hypertonic solutions. It can produce even pulmonary edema and so many other problems. Even some studies have shown higher mortality if you use hypertonic solution. Then coming to the isotonic solution, this is the backbone of, I will say it is definitely the backbone of resuscitation in burn patients. Isotonic solution keeps the cells healthy, everything fine, but it is not risk-free. If we give, it is required more because loss of electrolytes, the isotonic solutions from the change the capillary permeability is very high and fluid creep can occur and produce a lot of problems like cerebral edema, pulmonary edema, and over resuscitation can lead to reduced kidney, and under resuscitation also can reduce to reduced kidney function. So this is not risk-free. What we can do is, what people have done is that albumin has been added to this at proper time. The timing is not yet fixed till today. And so I think the isotonic solution with judicious individualized analysis and use of albumin will definitely be better.
Okay. Sir, have you any experience of using hypertonic saline in the past?
Yeah, when I started actually treating the burn patient when I was in Safdarjung Hospital, that time actually the hypertonic solution was discarded. People were not using it. I'm not much, and I'm not experienced with the hypertonic saline.
Okay,
I don't
sir.
have any.
Okay, sir. Sir, one more important thing is only one patient of electric burn in this group. So do you think this affect the incidence of acute kidney injuries in the study?
No, only one patient will not cause much problem. But we must know that electric burn under resuscitation can lead to AKI, and over resuscitation also can lead to AKI. So I don't think this will change much. What the type of study they have done is will two groups they have made and compared statistically. I don't think there is much difference.
Okay, sir. Okay, sir. Thank you, sir. Sir, what do you think the main cause of renal dysfunction in our practice, and how much is the incidence contributes to mortality in our burn patients?
Okay, in our burn patients, the cause of renal failure is basically under or over transfusion, delayed transfusion, and the patients are reaching. Maybe the patient population itself, that the change in patient population can be sensitive to one thing or other. That also, compared to Western, maybe they are more prone to kidney injury, and that's why we are having the renal problems in resuscitation period and during this period, initial period in burns management.
Okay, sir.
I think these are the things.
Sir, we are running short of time. We'll go fast, sir. Thank you, sir. Coming to the resuscitation volume and renal function, existing literature showing conflicting results. This study doesn't show any effect, similar to the Rizzo et al. Study. And a Manson et al. Study, they showed higher incidence of AKI if it is less than 4 ml per kg TBSA. And the Everett trial, they said that it is not feasible to lower below 4 ml per kg TBSA. Coming to the burn size and resuscitation fluid volume, when stratified by the burn size, the resuscitation demonstrates downward trend as burn size increased, and the smaller burns receiving higher volume per weight and TBSA compared to larger burns. This finding can be attributed to the potential over resuscitation in the initial stage and close adherence to the resuscitation protocol in patients with larger burns. Sir, my question is, mean TBS is around 22% in this study. Does this influence the results in this study?
No, they are made two group and both are statistically
Okay,
similar. I
sir.
don't think there is.
Sir, how does the depth of injury affected the resuscitation management?
Important. The depth of injury is if the deep burn is there, it is great risk of fluid shift and systemic complications. Deep burn can lead to hemolysis, may lead to myoglobinuria, and treatment accordingly as per electric burn. As like electric burn, keeping urine output above 100 to 150 ml per hour, and deeper injury can increase likelihood of infection, compartment syndrome, subcutaneous compartment syndrome, abdominal compartment syndrome. All these things will alter your fluid or treatment. Will alter the treatment, you can say, including fluid transfusion.
Okay, sir.
Even facial burn can be associated with the respiratory burn, and fluid creep can occur there, and they can produce problem, and early intubation or prophylactic intubation may be required.
Okay, sir. And the role of albumin and fluid creep. In this study, the use of albumin in resuscitation protocol has contributed to maintaining adequate urine output and limiting fluid creep. We'll skip this study with this slide, sir. The protocol preemptive use of albumin starting may be the key factor, may explain the difference in relatively less resuscitation volumes compared to the reported in previous studies. Who practice the albumin is used as a rescue therapy who has already received larger volumes. Sir, I think you answered this question. Do you agree with the use of albumin in the first 24 hours?
No, even American Burn Association, they have not advised within 24 hours. They have advised between 24 to 12 to 24 hours for only research purpose. Okay. And they say it should be individualized, closely monitored and guided by ongoing research.
Okay, sir. Okay, sir. Sir, any experience of using plasma during initial resuscitation?
Yeah, I have used, but no study. I have not done any studies. Definitely, it looks like it is very easy to maintain the vitals. And searching the literature, we find that it improves the epithelial function also. And epithelium is involved in the capillary in between epithelium, there will be capillary pores. And so the pore returns to normal very easily, and it reverts back to normal easily. That's what I can say. And other things, that what is the colloid pressure and
Yes, sir.
maintaining the plasma volume. All those
Yes.
things are normal.
Okay, sir. Sir, can we further reduce the resuscitation volume?
Yes, I'm already using 2 ml per kg per percent burn
Yes, sir.
very required. It can
Okay.
be reduced. But we will have to go for advanced monitoring and fix this protocol.
Okay, sir.
In the time permits, I will talk 1 or 2 points on this. Proceed.
Yes, sir. Sir, coming to the conclusion, the transition to the 3 ml per kg TVSA to isotonic saline appears effective in preserving renal function in severe burn patients. And the 3 ml per kg strategy combined with preemptive albumin successfully limited fluid creep. And there is a potential exit for further volume reduction through stricter individual titration. Sir, how does the tonicity of the fluid affect the burn resuscitation? Because
Tonicity.
in this study they didn't show any results, change in
Yeah.
result.
Tonicity. I'll tell you, there is a concept of compartment syndrome, subcutaneous compartment syndrome. If it is tonicity is less, more fluid creep, and more fluid creep, progression of subcutaneous compartment is very fast, and that will lead to problems, and even hospital stay will increase because in third stage of subcutaneous compartment syndrome, the necrosis settles and the wound becomes deep. And definitely, if you use hypotonic saline in large amount, that will lead to change in condition and increase hospital stay.
Okay, sir. Coming to the limitation of study, it is a retrospective study. There can be potential unmeasured confounding. In a single-stage study, limit generalizability, and the combined intervention, it is impossible to isolate the effect in both change in tonicity and volume. And the relatively low TBSA, there can be lower AK and RTT and compared to other studies. Coming to the future directions, future studies would focus on reducing resuscitation through dynamic individual strategies and prospective trials. The ABRA2 trials can put some light on the role of albumin burn resuscitation. Sir, what is the final take of this study, according to you?
Study they have proved that it is possible to reduce the crystalloid by use of albumin, and they have successfully used albumin within 12 hours. And it is feasible. They have shown that it is feasible and it is easy. But it is not crystal clear. The population is heterogeneous, and even IBA guidelines does not allow for the general population. I mean, for research purpose, they have allowed within 12 hours. Still, a lot of ongoing research is going on, and we will have to wait and watch for the albumin. Last trials, as you said, ABRA2 is going on, and this result definitely will be helpful in deciding albumin. Deciding when to give albumin. I mean, in view of capillary pore, it's a basic pathology. We will understand here that capillary pore is the basic pathology of the burn. Our aim of fluid resuscitation should be to change the capillary pore. The primary goal should not be what we are having now. Primary goal should be normalization of capillary pore before use of albumin and removal of inflammatory cytokines, which is cause of capillary pore changing. The secondary goal should be supportive, which is now current goal is secondary supportive goal. And fluid creep during this process of resuscitation is to be removed if needed by RRT and diuretics. We have done many studies on the AG ratio to caliber capillary pore.
Yes, sir.
In view of capillary pore as basic pathology of the burn, our aim of fluid resuscitation should be change the primary goal. What I mean to say, the primary goal should be normalization of the capillary pore before use of albumin and removal of inflammatory cytokine that is the cause of increased capillary permeability. Second supportive goal, secondary, we can say secondary supportive goal should be what we are having currently. The current target goal should be secondary supportive goal. Fluid creep that will occur during resuscitation, which is bound to occur, should be managed by RRT and diuretics. What I mean to say about the normalization of capillary pore is we have done a study where we do serial albumin globulin ratio, and the size of the capillary pore is 60 kilodaltran, and the size of albumin is 69 kilodaltran, and size of globulin is somewhere above 90 to 156 or something like that. So if the capillary pore is normal, albumin will not come out. If capillary pore increases, first molecule will come out with the albumin. If it increases more, the globulin will also come out of that. It means if serial changes in AG ratio we see, if AG ratio protein is reducing because capillary pore is increased and AG ratio is not altering, it means the pore size is very big, allowing albumin globulin in the same ratio going out. But if protein is reducing and AG ratio is changing, it means albumin is going out, globulin is not going out. It means the capillary pore is some intermediate, and normal will take as a first. So in between normal and this globulin leak, there is albumin leak. And if it is, we see that albumin globulin ratio is stabilizing, that is the earliest point where we can give albumin. That is best. Because when we give albumin and albumin leaks, it goes into extracellular fluid. And the half-life of albumin is 21 days. So you know that when the capillary permeability automatically will reach after some time because of the therapy, then albumin will remain outside. And half-life is 21 days. So you cannot, interactive edema cannot be avoided. And if this occurs in the pulmonary capillaries, though it is rare, the interactable pulmonary edema will occur. And it will be very difficult. Mortality will definitely increase. So we will have to work on this. And it's very possible. We can do in substance hospital these studies and can come out with the changing resuscitant goal, which whole world is still not doing. They are still at the level of whether albumin is given, not to be given. All those things are going on, but the cause is different. Think over this. It is the time to change that.
Yes.
I think we'll have to close
Yes,
it because already.
Sir, one final question, sir. At what time do you administer albumin, sir, in the initial part of resuscitation? At what time interval?
Yeah, that's very, very, very important question. And because what I do is nowadays I'm not giving, because after that study I have not done further study, which can be done now. When after 24 hours, when standard protocol of the resuscitation, when we are using fluid and we need more than 20-30% of that, it means the fluid creep will be maximum after this and there will be problem. And until 24 hours of proper treatment, it will reduce, it will be improving, you can say that. It will be reducing, the pore size will be reducing. And at that time, we individualize, we see the pros and cons of the albumin in that particular case, and then give albumin. It's no fixed protocol that after 24 hours will give. It's still not, because you read that paper of AG ratio to calibrate capillary pore, definitely you will be of the same opinion. And if you use, definitely you can reduce mortality and morbidity in these cases. Other things are also there in these cases where we have done serial instant blood volume estimation using chromium isotope. That also will give you more insight at more like a research to develop a protocol when albumin should be given correctly, correct pinpoint the correct point where we should be given. These two things definitely will be important investigation for research purpose, at least at this stage. Any other question?
Okay, sir. Thank you for the excellent explanation, sir. So thank you, sir, for joining us today and participating in this podcast and giving your valuable insight from your vast experience. And thank you, Navi team, for the opportunity. And thank you, everyone. Thank you, sir.
Thank you very much. Thank you.